Now let us find out what is the consensus point 3 that we would like to discuss. The next aspect that we would like to discuss, can we start ARNI de novo hospitalized patients with heart failure with reduced ejection fraction? I have already discussed how we differentiate a de novo heart failure from an acute decompensated heart failure. The main challenge that comes before us is, can we start ARNI outright in these patients? This is in fact an escalating challenge, and as per the global report heart failure registry of patients hospitalized for heart failure, 43% of the population were de novo heart failure, ranging from 20% North America to 79% in Southeast Asia. We know in Southeast Asia the incidence of de novo is much higher. In the PREVENT trial, 66% of the newly diagnosed heart failure reduced ejection fraction were de novo patients. Now if you try to put the sac valve in these patients, in de novo patients, so what this graph clearly shows that there was significantly lower incidence of composite of CV death, heart failure hospitalization in de novo hospitalized, heart failure reduced ejection fraction patients with the sac valve combination. This was the data as published in 2020, and then there was the ESC transition study where they tried to study a population of this post hoc analysis comprising hospitalized patients divided into subgroups based on heart failure study, whether newly diagnosed, that is de novo, or the chronic diagnosed patients. The primary endpoint was to achieve a target of 200 mg PD at the end of week 10 after randomization, and the secondary endpoint was initiating the sac valve after hospitalization in the newly diagnosed patients. Number 2, the proportion of patients who received and maintained any dose of sac valve more than 2 weeks leading up to week 10, and the rates of permanent study drug discontinuation due to the adverse effects. So if you try to analyze the changes in the echocardiographic parameters, because we know in heart failure patients we have to do serial echoes to know whether the patient is improving or not. These changes were in the reversal or the remodeling trials clearly showed that sacubital valsartan improved the cardiac remodeling and pump function more effectively compared to ACEI in de novo hospitalized HFrEF patients. So for example, it was seen that in the sac valve combination, 30% of the patient had an increase of ejection fraction to more than 50%, but only 6.5% with the ACEI or ARB. Similarly, led to end diastolic dimension. We know that if the end diastolic dimension is more than 5.7, it definitely indicates that the heart has dilated. Now, 26.7% of the patients with sac valve showed that there was a decrease of LV end diastolic dimension by more than 10 millimeters, whereas only 3.2% of the patient showed it in the ACEI-ARB arm. Another important aspect was that the sac valve reduces the high sensitive troponin D concentration in the de novo patient, and this significant reduction was seen to be as early as 4 weeks of randomization, and it persists more than 8 weeks, and it was seen that the significant reduction in the high sensitive troponin D with sac valve in de novo hospitalized patient with HFrEF. Now, it was also observed that the more de novo than prior heart failure with reduced ejection fraction patients achieved the target dose at week 10, and fewer had side effects and permanent treatment discontinuations. As you see these bar graphs, what you see is that the dark blue is the de novo arm of patients, and the light blue is patients who had prior heart failure with HFrEF. You will see the blue bars are all higher than the light blue bars. This establishes the fact that if we start these patients on sac valve as early as possible, our patients will benefit. So what does the transition study results teach us? The first line initiation of sac valve in de novo heart failure with HFrEF alongside the initiation of other guideline directed therapies is feasible and is associated with a better risk patient benefit profile than in patients with prior heart failure with reduced ejection fraction. The next most important take-home message that we get is that early intervention with sac valve should be considered to delay progression in patients with de novo heart failure, because you know that if you start them early, then definitely the heart failure, indices or the echo indices does improve. The 2021 update of the 2017 ACEI expert committee really showed that the first step of treatment of HFrEF with stage C, one has to prefer ARNI as a foundational therapy along with beta blocker and diuretics. Because of the new evidence that we are getting, ARNI is now considered as an alternative, also recommended in newly diagnosed or the de novo patients with heart failure, and clinicians should aim to achieve optimal GDMT within 3 to 6 months of an initial diagnosis of heart failure. Let us see what the ESC 2021 guideline recommends. The 2021 guidelines of ESC clearly recommends that ARNI must be considered as a first-line therapy instead of ACE inhibitors in heart failure to reduce ejection fraction. So it is not that we had the trials, now it has come to the guidelines that is most important. And if I pick up the 2022 guidelines of the American Heart Association, the American College of Cardiology, or the Heart Failure Society of America, they clearly state that in patients with heart failure reduced ejection fraction and NYHA class 2 to 3, the use of ARNI is recommended to reduce mortality and morbidity as a class 1 indication. So this will give us the confidence that in de novo patients, we have every right or every justice to be done, and evidence does state that these patients should be started on ARNI for better outcomes in the long run as early as possible.